Surgeons do all sorts of things to shoulders that I believe are unnecessary. I believe a very high degree of it isn't. They talk about different tears, the labrum tear and things like that. If you get a labrum tear, it's going to heal. If you have everything around that radius of that hub all working properly, it's going to get better. And in Paul's case, that you know, he had tears, and once they see a tear, it's like, oh, that's it. Tears repair all the time. You know, years ago, we wouldn't have even been able to find those on MRI to fix them. You fix them without knowing that. So we're looking at the hip problem. So we're going to evaluate your pelvis.
So make sure this one first.
If you like, that's relevant. So what we're looking at is that Paul's got a good range of motion with the shoulder. He's not really complaining about his shoulder. In fact, he says his left side, his right shoulder is better than his left side. But I'm evaluating him out, and I'm part of his maintenance program. So as I'm assessing some of the movements around that maintenance program, what I've detected is on the anterior serratus, a tightness where the ribs won't displace. I've found a rhomboid weakness that shows when we cross-recruit it, and the anterior serratus is shown to be too strong because we're putting a stretch test on it, and then it's testing weak. And the teres minor is testing weak aerobically. So that means I'm testing it once in the clear, stretch reflex is okay, aerobically 1, 2, 3, 4, 5. I get to about 5, it starts to weaken. So what I'm looking at is, because I've got good range and all of the other factors are good, then I'm going to start look at the facial band. But of course, that's where we always start. What's his pelvis doing? Because we haven't seen each other for a few weeks. And so we're looking at this band on the fascia that comes right from the perineal and posterior tibialis sling of the foot.
Into one shoulder.
Yeah. It comes up the body. It comes up the back of the hamstring.
No.
Oh, sorry, yeah. This one. Are you describing it? Yeah. So as it's coming up above the knee, you can see it above the knee. So you just
use better off starting there.
Right.
From the front.
Right.
Because it comes across.
So it's coming up the peroneus muscle.
Anterior tibialis.
Anterior tibialis. Sorry. It's coming up the facial band here. It goes to the relay point on the anterior superiliac spine. It then comes across the rib cage. It becomes the anterior serratus muscle. And then as it comes around the back, it becomes the rhomboid muscle. Then it becomes basically the upper trapezius on the opposite side and goes to this mastoid. So you can see that total spiral line is affected, especially with what Paul does as a plaster. He's reaching up and wants different rotational qualities in his arm. He's able to do that. He's got no pain. But as part of the maintenance program, I've detected those faults. Now, I haven't evaluated his pelvis for a while, so I'm going to evaluate the pelvis, and hopefully the answer will show that the anterior superiliac spine is not the right nodal point for the cross-facial pattern, and that's causing these little problems here. If they clear away when I've done this, I'm straight out the woods. If they haven't cleared away, the pelvis still needed balancing, but I know now that that's not the nodal point that's affected. So it's the facial band as it comes further up and goes around to become the rhomboids and anterior serratus. So I'll address it more locally when we come to the ligament part. So if you jump back on, Paul, I'm going to check your fossas. Yeah. I'm making this one here for myself, as usual. So what we're finding is a lower fossa. Let's see if we've got a gate fault as well. Say, yeah, we've got a gate fault. We've got source is okay. Facial band isn't okay. Inversion isn't very good. Eversion is good. Inversion isn't so good. So that's going to affect the tibial band sling. That could be coming up to here. We're coming to the node point. So I'm now on the anterior superiliac spine. And I'm going to extend a line diagonally towards the midline. So I've got a finger on the anterior superior leg spine, a finger going towards the midline, whatever your hand spreads, and I'm going to approximate that, and now I'm going to spread it. Now when I spread it, I get a response. If I spread the other side, I don't get a response. So if I follow that line up a little bit, and I'll go to the bottom of the rib cage wherever it diagonally meets, and I'll go towards the anterior serratus and spread that. So again, I'm stretching that, and it says, don't like that. So that band is under stress. So that could be pulling this slightly forward and causing all of those problems in there. So I'm going to make sure we haven't got a scratch test, which we haven't, on either side. So we've got a slight pelvic imbalance. I'll just check some of the things that Paul normally shows, and actually none of them are showing. So I've got a bladder 62 on the outside of the ankle. I haven't got a kidney 6. I haven't got a stomach 36. I've got a gallbladder point as I come up, and I've got GV30 as I come a little bit higher. So I've got a couple of gallbladder points. So I'm going to address the.
Can I ask you anything?
Yes, yeah, absolutely.
What I was feeling, especially last week, on both.
Yeah, just sit up and tell us.
On this. I'm feeling, and is that me tibial? Is that where the facial
band is? An anterior tibial. Yeah.
I know you've done the scratching, you've just me, but I really stripped that out last night. I'm feeling it's hard all the time.
Right.
And I'm feeling things in them.
Right. Now again, what Paul's exhibiting, he stripped all of this out last night. So he's took away some of the evidence that maybe would have shown us a clearer problem because he stripped it out. But it's coming back and starting to tighten up. Now, it'll take quite a while to get rid of all of this stuff if it's been postural for a long time. I know when I got the hips done, I had to strip these out for months until there's no longer a problem, because they shorten. And again, they're causing tibial band problems right to the opposite mastoid. So I'm just going to do the bladder point and get the eversion and inversion working better. I'll come up to the knee. The fibula doesn't want to move backwards into its translation. I've just gripped it and he's just winced. So I'm in the area of stomach 36. I'm also at the back of the fibula, so I'm affecting the gallbladder channel, gallbladder 34 there. As I come down, I'm stripping down. And as I'm stripping down, I agree with him that we've got a tight perineal band or tight stomach meridian also. But not a scratch test. And as I was saying earlier, especially to you, Rebecca, if we had a scratch test, you've got to work those feet or the joints in the ankle. You've got to get rid of that scratch test. But once it's gone, it's still causing aberrant interference. So then you've got to find out which part of the muscle is still sending nociception, if any, up through the nervous system. But if it's a scratch test, it's actively doing it. If it's not, it's dormantly still, it's dormatized to you, but still sending aberrant signals up. So we give that a strip out. We come to the points on the facial band here and just below the femur head, and I'm just going to load that and let that repartition itself. And I'm not doing anything else to see if that's affected the fossa. You've been walking around Newcastle shopping, things like that, hard surfaces, different shoes, all sorts of things, so it's just caused a little imbalance. But now the fossa's back intact. So I've got the fossa intact. That's what I was after. So I'm now going to the ASIS.
Can I stop you there?
Yeah, stop me.
The fossa is back is intact because you've done that there.
Yes,
Stripped it out.
Yes, yeah.
Right.
So rather than do a source release, I'm figuring it's come from the foot. You lost a little eversion. So I came up through. I've stopped the aberrant. I wanted to do as little as possible. I wanted to do as little as possible to get my fossa in. Because once the fossa is in, the anterior superior spine is in the right place. Now, what we're looking at before is, if it was posterior or anterior, depending on which fossa's out, it's going to cause a pull as a nodal point. So I've got to reposition that and say, right, now that's the compass point where it should be, I can now assess the facial band and see what it's doing now. So I'm taking my finger on the anterior superior spine, I'm pointing diagonally towards the midline of the body, so diagonally and up, and I'm stretching my fingers apart, and I'm approximating them and stretching them apart, and neither of those two give a signal. The one way I stretched apart before was giving it an burn signal. So I'm coming a little bit further up, under where it meets the rib cage on the liver, and I'm stretching it, and it says I'm fine. So we come a little bit higher. So we now go to the anterior serratus, stabilize the bottom of the scapula, pull, lengthen it, as we did before, and pull, and it's now absolutely locking strong. We roll them a little bit onto the opposite scapula to stop the inhibition for the rhomboid. I take the rhomboid into position, and it's absolutely strong. The next one that was weakened by that scenario was we had an aerobic teres minor. So I'm going 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Gone. So all those three things have gone. So now I can go back to the anterior serratus, and it displaces. It's displacing lovely, which is now, that upper restriction is totally gone. So we'll ask Paul to sit up and move his arm, stand up as well, move your arm in different directions and see if it's freer for the benefit of that. Yeah. And so you can see he had a shoulder problem that if left would actually become a shoulder problem. But if you don't pay attention to these node points and these crossover fascias, you're in the wrong place. You see that? That's why we treat the whole body all of the time and understand the dynamics of each part of the surface of that wheel and the hub and the spoke, all being able to displace the weight in the right places. Because if it can't, that scapula doesn't sit right. If it doesn't sit right, you lose something. Then you get bursitis or whatever it is you're going to get from there. And it doesn't have to be from there. As we talked earlier, even the liver being in a stuck position can cause shoulder restrictions. So hopefully that really helps with the sort of evaluation you want to be able to do on there. Okay.
Yeah.
So I explained that. So now we'll look at